Morning.
Okay. How's everybody today?
Oh, all's good. All good.
Okay. That was some silence.
Morning, Jimmy. Hello. Jimmy, can we before we started, can we check the sound?
Hi everyone.
Yes, very loud.
Professor, can you hear me?
Yes. Hello. Good morning.
Good morning. Yeah. How's everything in Malaysia?
Not so good. Not so good at the moment.
Facing a lot of challenges.
Yeah. It's quite a challenge. I think there's still quite a number of cases. Deaths have been rising also with this current wave. Have been more than we thought. So on average, I think we are we are a bit worse on the on average, I think, compared to before.
Yes.
Hopefully,
Unfortunately, I think we in Taiwan we also went through this difficulty. But very fortunate during this week we see our number has gone down to single digit.
yes.
So I think well this is a good time we can share from each other our experience. This conference we can come up with some good solution suggestion to both sides.
Yes.
Thank you for participating in this.
Oh, thank you for having me. Yeah.
Good morning, Prof. Pang.
Hi, Professor Danny. How are you doing?
All good here. Can you hear us well?
Yes, I'm now with Professor Lin here. So we're waiting for our Professor Chu, Vice Superintendent. He's the head of the Infection Control Committee. So I think we are looking forward to this meeting, and we can share with each other the experience we have, especially during this. I don't know how to call it. It's a third wave or fourth wave. I don't know, but this this time of the year is another challenge. And yeah, Professor Chu is here.
这个是马来西亚，在我们这边
欢迎。
started 的那个
OK。
你要不要坐？拿个椅子坐那边。
Yes, we just had Professor Chu and our Vice Superintendent join us. I think he's the most experienced person in this hospital now to in terms of this COVID-19 experience and controlling and governing the whole policy in this hospital. So we are really looking forward to learn from each other, especially during this challenge of time. Yeah, hope that everything will run smoothly today.
We hope so too. Tarani, is Victor joining us?
Yes, Victor is joining us, but he's not signed on yet.
Right. Zura should remind him or something.
Yeah, I already texted Prof. Victor.
你还有没有一个小荧幕？要不然我看我们小的长官哈，这个头都要很辛苦。这里
等一下上面会出来吧？
他也会分享，
哦，
就是说，
那就是看不到。
我怕你这头太
那个上一次，你是 care
贴了，
对，
which one？
我之前是我是那个马来西亚卫生部的金融活动那边，
哦 ，GH，
对 GH。
那你别的，你是哪里毕业？
我不是 UM， 我是那个国民大学 UM。
我刚好疫情期间你过来。
对啊，他12月来。
我12月。
去年是
一年，我快回去了，3月。
还有菲律宾的学生要申请到来进来，这样不然不能进来，3个人。
这要靠我求索，就团队打结合美好的战。这个时间刚好，你看你把它压到这么低，可是马来西亚还是
这个那很危险
不知道为什么。
对啊，
跟我们生意没关系。Professor Tani, can you hear us?
Yes, we can. I can hear you very well.
I think the time is ready. We are ready here. I Yeah.
Can you
Okay.
start first?
No. Yeah. It depends. Okay. We are online now. I don't know. Is it?
Yes.
Online? Okay. Professor Tarani and Professor Awang, and also a good friend in UM, and our Vice Superintendent, Professor Chu and Professor Dean. And also, we are happy to have one doctor from Malaysia visiting us in Changan. Dr. Chang is with us. And all the to all the friends and audience online, thank you for joining us for this special conference or special meeting between UM and Changan Memorial Hospital. I think we chose this topic. It's very challenging and also very interesting because this is a time that we are all facing a new challenge. Since the pandemic happens last year until now, it's almost coming to 2 year time. But in the beginning, we thought we can control and contain the pandemic, the outbreak. But unfortunately, the new COVID variant has changed everything. So I know that from the news, Malaysia having this challenge, and especially now still have more than 10,000, 20,000 cases per day. We, Taiwan, also suffering this pandemic, the outbreak in May. To us, probably is a second wave. We didn't expect that we would have a small outbreak here. But fortunately, we managed to contain it so far. Until yesterday, we only see single-digit cases. But I'm sure that this is also a very challenging time because once we lose our control, maybe we will face another surge of the cases in our community. So I think it is a good time that we both come together and discuss and sharing each other's experience and hope that we can find a solution to end this challenge, this war against COVID-19. So I will give a small briefing. Maybe we would like to hear something from UM, Professor Tarani. Can you give us some comments?
Thank you, Prof. Pang, and good morning, everyone. Yeah, welcome to the CGMH and UM joint webinar. Okay, UM and CGMH, I understand, have been working together and have a memorandum of understanding since 2019. Okay, since in 2019 we were fortunate enough to be able to visit each other. So a delegation from Taiwan visited Malaysia in April. And a team from University Malaya also visited Taiwan, I think in November of 2019. Since then, our collaboration has evolved, sharing and webinars, joint teaching, and we hope that we can further do more collaboration on research and so on. Okay. Currently, our world has been constrained by COVID-19. The pandemic has made our world smaller. But I hope that we can work together and share experiences today on our fight, I would say, our battle with COVID-19 and the different points of our journey. So currently in Malaysia, we are facing an upsurge due to the Delta variant. Okay, but that being said, our vaccination program is quite successful, and to date we have been vaccinating about 40% of our population. Okay, so we hope that this and other measures would help us combat COVID-19. Okay, please give me a chance to introduce my colleagues. Here, I am Dr. Tarani. I'm a public health medical specialist from the Department of Social and Preventive Medicine. Okay, over here today, I have two distinguished speakers from Malaysia. One is Prof. Dr. Awang Awang Mahmud. He is an epidemiologist and statistician at the Department of Social Preventive Medicine, Faculty of Medicine, University of Malaya. He is the first Malaysian doctor to gain a PhD in health informatics, and he is currently leading the independent COVID-19 Vaccination Advisory Committee in Malaysia, and has a large research project entitled SEED, which is the COVID-19 Epidemiological Analysis and Strategies. He is also currently the Secretary General for the Academy of Science Malaysia, Council Member of the Academy of Medicine Malaysia, and President of the APAC KL, which is the Malaysian chapter for the Asia Pacific Academic Consortium for Public Health. He was Project Director for the Malaysia's National Policy of Science and Technology and Innovation from 2021 to 2030. Prof. Awang is active in research and has published more than 100 Web of Science Index journal articles. Okay. I would also like to introduce Prof. Victor Ho. Prof. Victor Ho is the Professor of Occupational and Public Health at the Department of Social Preventive Medicine in Faculty of Medicine, University of Malaya. He is also the head of the Department of Social Preventive Medicine in University of Malaya and the head of the Public Health Department at University of Malaya Medical Center, which is our affiliated teaching hospital. He is part of the UMMC COVID-19 task force in the hospital, and his role in the task force is to manage environmental issues at the UMMC and to reduce the risk of transmission of SARS-CoV-2 in the hospital. He is also part of the team that developed the UMMC risk assessment and surveillance system that keeps us all safe. He holds a PhD in occupational health and safety from Monash University in Melbourne, Australia. Thank you so much. Prof. Pang, can we start the first session? Prof. Pang? Before we carry on, could I invite the audience to type in questions into the chat box? We will deal with Q&As at the end of the section.
Okay, sorry, it was mute at the time previously. So I would like to introduce our first speaker, Professor Lin Suning. Professor Lin is our current COVID-19 Referral Center director, and he also involved in the Taiwan COVID-19, the member of Taiwan CDC and Critical Care Consultation Committee. I think Professor Lin have put a lot of effort helping our hospital and also giving his expertise consultation to the nation regarding the COVID-19 contain policy and all these taking care of the patient. I think he is well experienced, and today we are very happy that he can share with us the current situation in Taiwan and probably his own experience during with COVID-19. So let's welcome Dr. Lin, Professor Lin, to give us this special lecture.
Thank you. Thank you for the moderator's kind introduction. And it's my great honor to be here to talk about the condition of COVID-19 in Taiwan. And the other part, I would like to share some experience from our hospital. So let me start the first slide.
休息一下，用这个医生你
然后这就
OK，
看这个播放，看看这个播放。所以我们要关掉我们这边的声音。那边静音关掉。
to talk about the situation in our hospital when we are treating the COVID patient. And as you know, there is an outbreak in Taiwan since this May. And until now, we have more than 15,000 patients with confirmed COVID and more than 800 deaths in this country. And this is the density of case in deep purple means a higher density. For those with the pink color, it means the density is lower. And you can see that most of the new cases arise from the north of Taiwan. And this is the number, the daily new cases in Taiwan. And you can see there is some new cases in Taiwan, and the government started a level 2 alert. And in May 12, we can see the level 3 alert only in north of Taiwan. And unfortunately, after 1 week, the government announced the level 3 alert in the whole island. And you can see after the outbreak, 2 weeks later, the mortality case rise rapidly, and you can see the trend. Actually, we are gradually control the daily increase of new case within 1.5 months, and the mortality case actually decreased gradually. And what the level 3, and all the students receive online lesson in their home, and all the employees can can work at home and taking care of the children, and they may be paid or not unpaid by their boss. And for many business and office are, although they are open, but actually we have some restriction about their visitor or their entertainment venue, and including cinema, sports center, library, all closed. And more than 5 people gathering indoor or 10 people gathering outdoor were prohibited. And all the restaurants are not allowed it for dining in, only taking out or deliver service only. So that's how we control our community spreading of COVID. And after the outbreak, I think the government pushed the vaccine policy very rapidly, and you can see the rapid rise of patients who receive vaccination in Taiwan. Until now, we have more than nearly 10 million people receive at least 1 shot of vaccine, and around 40% of the population were vaccinated. So that's why we can control the case number in here. This is the latest condition in Taiwan. As you can see, the highest infection cases on May 26, about 600 patients per day. And now we can see that we have around 2 weeks of new case, only less than 10 cases per per day. So I think the conditions will gradually improve in Taiwan. And how about we are dealing with this COVID patient in our hospital? This is the guideline in our hospital. We adapt the guideline from Taiwan CDC COVID-19 treatment guideline, and we are classifying those patients into 4 categories: mild, moderate, severe, and critical, according to their symptom. For those without any symptom, asymptomatic COVID were not admitted to the hospital. They kept in home or to quarantine isolation at the other institute. But for those with symptoms, they were admitted to the hospital. For those mild, the only symptom with fever, but without any oxygen problem, they were classified as mild. For those with pneumonia on chest X-ray, but with under room air saturation more than 94%, they were classified as moderate. For those with respiratory distress and also desaturation less than 94%, we are classified as severe. For those with severe COVID, we started oxygen therapy and thinking about the awake prone for those patients. And we are started to give some specific medication. For instance, dexamethasone, remdesivir, and for those with hyperinflammatory status measured by CRP more than 75 milligrams per liter, we started 1 shot of tocilizumab. For those with respiratory failure, even developed into ARDS, we started from give them a mechanical ventilator. And this is our daily regular examination about the COVID patient. In day 1, we have some regular examination recommended by CDC guideline, and including the CDC, some organ function, and most importantly, the marker of inflammation, including CRP and IL-6. And every 4 days, we follow some specific biomarker to validate their condition, and also chest X-ray. And we established a multidisciplinary team in Changchun Memorial Hospital. Actually, this team has been established for more than 1 year, and since the outbreak of COVID in other countries. This team includes the pulmonologist, infection specialist, cardiovascular doctor, nephrologist, and cardiovascular surgeon for preparing ECMO, anesthesiologist, ENT doctor for emergent tracheostomy, and nurse team, and also respiratory therapist, also dietitian, infection control team, and administration team, which give us some connection help in all the teams connection. And we have a daily meeting about each case for their disease treatment. We reach some consensus among all these members, and then we set up a timetable for teamwork. How can we deal with these patients in isolation room? We don't want our healthcare worker get into the isolation room too frequently. So we collect all the necessary treatment in one time when our healthcare worker go into the isolation room. And about the treatment of hypoxemia in ARDS, we have some basic principle. First is the lung protection strategy. We try to protect our lung for overdistension. So we decrease the tidal volume to less than 6 milliliter per kilo, and maintain the plateau airway pressure less than 30 centimeter. And we set up a target of saturation more than 88% with a pH value more than 7.25. And if the severe hypoxemia happened, we started to give sedation and neuromuscular blocking agent, and consider prone position when patient can tolerate. And some selected cases we give them ECMO using ultra lung protection ventilation to as a salvage therapy for severe hypoxemia, which are refractory to our lung protective strategy, and conserve the fluid therapy to keep adequate oxygenation. And about the mechanical ventilator, we have some key points. We hope we do not delay intubation, and that can save the patient from severe hypoxemia. And the timing of adjustment of our ventilator setting and blood gas sampling need to be scheduled every day, and avoid the nebulizer, because this may cause some spreading of the virus in the air and may have some infection dangerous to our healthcare workers. And due to the sedation, the patient is immobilized, so some lung collapse may happen. So this is we need to taking care of those special problems. And thinking about the weaning process, we hope that we can have some safety control. So we need to check the weaning profile, the cough leak test, and try to extubate the patient safely and avoid reintubation, because they may cause some danger about the healthcare worker. And think about the prone position. They can lots evidence support the use of prone position in patient with ARDS, but not every patient can tolerate prone position. According to our estimate, around 30 to 40% can use a prone position, because we need to think about the body weight of the patient, the condition of the patient. For those with overweight, there are some difficulty to have them in prone position. And using prone position, we need to avoid the choking and the sliding of some catheter, including endotracheal tube and the CVP line. For those without respiratory failure but have hypoxia, we think about the awake prone. But consider the evidence in awake prone, I think it's not very clear for their role in reduce mortality. So we did not routinely use awake prone. We only use in selected patient. This awake prone can definitely improve oxygenation, but it's a relatively easy to use. Patient can prone by themselves, and when the patient uses non-invasive ventilator or even high flow nasal cannula, they can also use this position. However, the mortality, the evidence of mortality is not so strong, so we only suggest some patient to use this awake prone. And this is our algorithm in dealing with COVID patient. First, we need to evaluate their age, comorbidity, organ function, and some biomarker about the inflammation status and oxygenation and the severity on chest X-ray. For those with low risk, we keep conservative treatment. And for those with hypoxia, we consider give oxygen therapy and some specific drug like remdesivir, dexamethasone, tocilizumab. And for those not improved, we switch to mechanical ventilator. For those with ARDS, we started to change our ventilator target, and we evaluate their condition about the inflammatory status by CRP and their organ function, chest X-ray severity, ventilator setting. For those not improved, we need to think about if there are some development of nosocomial infection and some chance of viral trauma development, and maybe the worsening of their comorbidity, because those patients are elderly patients. And so this is our thinking process and our protocol for treating COVID patients. So in summary, I think ARDS may develop in COVID-19 patients, so we need to take care of their situation of rapid hypoxemia. And we recommend guideline-directed therapy for COVID patients. And to deal with this patient, we definitely need a multidisciplinary teamwork to dealing with this complicated disease. And non-protective strategy, prone position, sedation, and ECMO for ARDS are selective used in those patients. And I think age and comorbidity are very important in impact of the patient's outcome. So we need to hope we can prepare everything in advance to prevent any danger infection of our healthcare workers. Thank you.
Okay, thank you very much, Professor Lim, for your excellent talk and sharing with us some situation in Taiwan and also especially your experience in treating patients with COVID-19. So I think we will have a time maybe receiving questions from the audience. Probably we will go back to event side and I'll let Professor Tarani to introduce the next speaker.
Okay, thank you, Professor Lim, for your excellent speech on management.
Cannot hear you.
Cannot hear me.
Yeah.
Can you hear me?
Yeah, no. Okay, good. Thank you.
Yeah, thank you, Prof. Lim, for your excellent speech. I would like to introduce now Prof. Awang Dubigitla, who I had introduced earlier as an epidemiologist and statistician at the SPM department. He is the lead of the independent COVID-19 Vaccines Advisory Committee in Malaysia and also the Secretary General of the Academy of Science Malaysia. His list of accomplishments in this country is in the area of science and technology is very is indescribable. Can I introduce Prof. Awang to share his experiences? Thank you.
Thank you very much, Dr. Tarani. Let me just share my slides. Can you see my slides?
Yes.
Yes.
Right. Thank you very much. I'll just give some updates that wouldn't take more than 10-15 minutes of your time. So this is just the outline of my presentation. A bit of situation analysis, our policy responses during the first MCO, the movement control order, and the subsequent control orders and so on. Then the policy responses to the third wave and our vaccine policies. So as you know, worldwide, as of today, there are already more than 210 million cumulative COVID-19 cases, which gives a rate of about more than 27,000 per million people. And there have been more than 4.4 million deaths, which is about a rate of 560 per million. In Malaysia, we have logged more than 1.5 million cumulative COVID-19 cases, which gives a rate of about 47,000 per million population. And we've had more than 14,000 deaths so far, which is about 430 deaths per million population. So as you know, many countries have tried all sorts of strategies to deal with this. And it started off with the COVID-19 being solely under the purview of the Ministry of Health in Malaysia. There were just imported cases at the end of January and in February 2020. But in March 2020, the second wave of infections hit Malaysia, and a very large cluster, which involved a religious group, happened then. So the overall management of the pandemic was taken over by a group of people called the National Security Council, which combined several ministries. So we had our first lockdown, the movement control order declared on the 16th of March last year, and it took effect on the 18th of March. So what happened during this lockdown? All international borders have been closed, and except for Malaysians wishing to come home at that time, there were interstate travel, which was banned, and a lot of businesses were closed with only essential services being allowed, and social and religious gatherings were banned. And the armed forces were co-opted to assist the police force in enforcing the movement control order, or the MCO. So this was the first MCO. There were a number of public health interventions to support this first MCO. Block contact tracing, quarantine centers were set up, and a number of task forces were set up by the Ministry of Science, Technology and Innovation to do with epidemiology, engineering, testing, vaccines, and app development. Because a lot of businesses suffered from the movement control order, the economic effects were felt by a lot of people, and the GDP growth slowed down in the first quarter, and Malaysia last year at that time barely escaped a recession. So the GDP shrank in the second quarter, and the restrictions were eased in subsequent movement control orders, what we call the conditional movement control orders, the CMCO, and later the recovery movement control orders. So recovery stimulus packages were also introduced called Prihatin, Prihatin Plus last year. And during the conditional movement control orders and the recovery movement control orders, businesses were allowed to reopen except for entertainment outlets, earlier on sports, hair and beauty salons. Intrastate travel was allowed, but interstate travel, international, was still not allowed during the conditional movement control order. Religious festivals were still severely curtailed with many restrictions. But under the recovery movement control order, almost all sectors were allowed to open, and the government also allowed schools to reopen with certain stimulus packages to enable more businesses to reopen. So businesses began to open under the RMCO, the recovery movement control order, and the number of stimulus packages also quite a bit. By the time we had reached the RMCO, the government had announced 5 stimulus packages. So during the conditional movement control order and recovery movement control order, cases went down to just single digits. On 1st of July, there was just 1 new COVID-19 case. But after 31st August, which incidentally is our Independence Day, last year, new infections rose, giving rise to the third wave, and we are still in the third wave. I don't think we can call it a fourth wave because we never really got out of the third wave. The start of the third wave was because of the state elections, which were forced in the state of Sabah. This is on the island of Borneo. And what happened is that the cases, because of the increased movements during elections, the number of cases rose dramatically in the particular state, with doubling time, I think, reduced to just 10 days. And people coming back from Sabah back to the peninsula, the returnees caused a lot of issues. And by October 2020, 1/3 of the clusters in the state of Selangor, which is the most populous state in Malaysia, were linked back to Sabah. So the government then introduced a number of movement control orders again, which was confusing in some ways. So to summarize the movement control orders, we have been going through movement control order 1.0 to the conditional movement control order to the recovery movement control order, and then we started again with the second movement control order, which is the MCO 2.0. So all the movement control orders have been based on the application of 2 acts of parliament, Act 342, which is to do with prevention and control of infectious diseases, and Act 344, which is the Police Act. And for the state of Sarawak, it has to do with the Sarawak Protection of Public Health Ordinance 1999. Now, we are still in the MCO 3.0 with some degrees. This started in May this year, and there was a national lockdown from 1st of June. We are ostensibly in the National Recovery Plan in phases, so there are some states which have varying phases. So the most populous state, which is Selangor, together with the Kuala Lumpur, are still in phase 1, but a number of states have entered phase 2, 3, and so on. An enhanced movement control order, which is a very targeted lockdown, has occurred in some localities. They are on and off depending on the severity of infection in those places. So because businesses suffered again because of the restrictions in movements and so on, the government introduced this National Recovery Plan, which had certain indicators on what could be considered a threshold for moving from phase 1 to phase 2 and phase 3 and phase 4. So these are the other stimulus packages which have been introduced. Now, Malaysia has not done very well in controlling the number of COVID-19 cases due to various factors, but it has done, although quite late to the vaccine program, it has done fairly well in trying to vaccinate its population. So as of September last year, when the COVAX agreement actually, the deadline for signing COVAX with WHO, Gavi, and CEPI labs. Malaysia had not signed it, and it was signed quite late, up to November. But in the meantime, the government had been negotiating with several companies to try to get vaccines, and the first agreement was signed in November last year for Pfizer BioNTech vaccines. And subsequently, the government procured other vaccines: AstraZeneca, the Oxford vaccines, the Sinovac vaccines. Even signed agreements with Malaya for the Sputnik V vaccine, although that vaccine has not yet arrived, and signed another agreement with CanSino and also Johnson & Johnson and Sinopharm vaccines. So to date, there are a few vaccines which have been approved in Malaysia, and these are the list. There's a Pfizer, AstraZeneca, the Sinovac, CanSino, Johnson & Johnson, Sinopharm, Moderna, but we have not received we have not approved the Malaya Sputnik V, although the agreements to procure have been signed, but it has not been approved. So far, the Pfizer and AstraZeneca has been used, so has the Sinovac. CanSino has just arrived. Johnson & Johnson has not, but Sinopharm and Moderna, they have been approved, but not procured yet. So to run the vaccine program, there are a few committees. The main committee is called the JKJAV. There are other subcommittees under it. But to implement it, there is a trans-ministry task force called the Covid-19 Immunization Task Force, or CITF. There's also an independent vaccination advisory committee, in which we have epidemiologists, immunologists, virologists, health economists, occupational health physicians, ID physicians, pharmacoeconomists, and even ethicists. So we started our NCIP, or the National COVID-19 Immunization Program. There are large vaccination centers which are in use. There are mobile vaccination centers. There are community vaccination centers. And in addition to all these other things which have been happening, our own department has been involved in several projects also to help the government, to advise the government. The first is to look at the analysis of the data to do with COVID-19. The second is to do with the Vaccination Advisory Committee. And the third, because of the surge of infections within the Kuala Lumpur and the Greater Klang Valley area, a task force was set up, which involved also academics from our department. That's all from me. Thank you very much, Dr. Taran.
Thank you, Dr. Prof. Awal. That was very interesting. Let me hand the session back to Prof. Pang to go on to the next topic, which is challenges of healthcare services during COVID-19 pandemic in Taiwan and Malaysia. Prof. Pang.
Okay, thank you, Professor Wang. Very interesting and very useful information for us. I think we see that this infection control and between infection control and the economic activity maintenance is very difficult. So now we are going to another topic, will be the challenges when we're facing this pandemic. I would like to introduce our next speaker is Professor Chiu Zhenxu. He's, I should say that he's one of our heroes now, especially in Chang'an, because he's sitting on the position of the COVID-19 control committee in this hospital, and also helping the nation to fight this pandemic. And Professor Chiu himself, he's a well-known, expert in pediatric. He published a lot of papers, especially in one of his main paper in New England Journal of Medicine. So we are very fortunate to have Professor Chiu because he devoted himself during the past 1 year or 2 year time now, almost fighting, helping us to get control of this disease, this infection. So today, we are looking forward to hear his talk, and especially he will share with us the challenges, and I'm sure that he will bring up his own experience as well, and also
how he helped us to control this pandemic. So let's just welcome Professor Chu.
Thank you, Professor Fong, for the kind introduction. I think during the pandemic, there is no hero. We just work together, hopefully to contain the spread of the virus. So today, it's my great pleasure to join the online interactive section and with our professors in UM. So today, the topic of my presentation is challenges of healthcare service during the COVID-19 pandemic. So in terms of how to maintain the safe healthcare service during the community epidemic of COVID-19, I think there are 4 very important actions that we should take. Firstly, from the hospital perspective, we should reduce the hospital operation load. And secondly, we should do whatever we can do to prevent in-hospital outbreaks. And thirdly, during the pandemic and also during the recovery phase, we should screen all the inpatients and also accompany persons to prevent in-hospital spread of the virus. And fourthly, we should screen during the pandemic and also in the recovery phase, we should screen all outpatients who need invasive procedures, either for diagnosis or for treatment during the COVID-19 phase. So in terms of the decrease of hospital operation load during the community epidemic, we can restrict the outpatient number, and also we should restrict the admission of inpatients to the hospital, and we should postpone all the non-urgent operations to the later stage of after we control the epidemic. And also we should postpone all the non-urgent procedures. And regarding the preparedness of the infection control to prevent hospital clusters, I think there are a few measures that we should take. And the most important one is to implement based on patient risk stratification. And this is the most important measure we should take to prevent the spread of the virus in the hospital during the epidemic. So first of all, we should triage all patients before they enter the hospital. So in our hospital, at all the entrances, we do triage for all visitors. We check temperatures for all the visitors. And we also check the health insurance cards of all visitors to take the travel history, occupation history, and also exposure history of all the visitors. And for those who have symptoms, based on the severity of the symptoms, if they have only mild symptoms, they will be led to the epidemic clinic to seek for medical service. And if they have more severe symptoms, including fever or any respiratory symptoms during the pandemic, they will be led to ER, outdoor quarantine station, for further assessment. And if necessary, they may be admitted to the hospital for further treatment after screening. So for those all with symptoms, basically they cannot be allowed to enter the hospital before their risk is clearly determined. And here's some pictures showing the epidemic clinic of our hospital. This epidemic clinic of our hospital is actually located in a remote corner of the campus. And this is a very good location and an area with independent entrance and also adequate outdoor space. And and this allows us to design the independent route for the transportation of the patient. And also this epidemic clinic during the recovery phase also is also for the responsible for the screening PCR for all the patients who need admission or procedures during the community epidemic. And our ER actually generate and provide comprehensive ER protocol for the risk assessment of all the patients who visit ER during the epidemic. And based on the risk assessment, all the patients will be led to different routes for further medical service. And again, our ER generate strict protocol for screening of the patients. And all the screening actually basically is done in the outdoor quarantine space to assure the safety of the procedure. And after the risk assessment, we provide strict separation of inpatients for further treatment based on their risk assessment. So for those who are highly suspected or confirmed to have COVID-19, they will be led to the so-called red zone, the negative pressure wards for further treatment. And for those with initial negative screening result, but still suspected to have COVID, and they will be led to the so-called the quarantine ward, which is the yellow zone for further treatment or assessment. And they only when any person who are admitted to the red zone or to the yellow zone, only when they are confirmed moved to the general ward, so-called for the step-down management. This is a map of the hospital campus at the center of the campus, and all the patients with symptoms actually received risk assessment at the ER, at the outdoor quarantine station of the ER. And we designed specific, specific independent routes for the patient transportation, just for the safety of the staff and also for the patient. And again, this is the routes for the patient who are going to be admitted to the yellow zone. And our hospital also set the outdoor pharmacy to provide pharmacy service for all the outpatients of Tangga Memorial Hospital. We just try our best not to allow many patients or many visitors who enter the hospital, just to reduce the risk of cross-contamination from the outside environment. And some patients, if their initial screening is negative, will be admitted to the so-called green zone, the clean area, for the treatment. But for all the inpatients admitted in the green zone, we still closely monitor their treatment course and also clinical course, because they may still get COVID-19 infection, although their initial assessment is negative. So we set up a strict protocol for the evaluation of inpatients with unresolved respiratory tract infections. And for those who were screened negative before admission, if still suspected, or if they still have unsolved respiratory tract symptoms or signs, repetitive PCR will be provided after ID doctor evaluation. So with this protocol, actually, we pick up some cases who actually missed in the initial screening protocol. And we just manage them just on time to avoid the widespread of the virus in the hospital. So we actually reduced many occurrences, possible occurrences of the outbreaks or clusters in our hospital. So, and to prevent the spread of the infection in the hospital, a very important procedure that we should take is to provide guidelines for healthcare workers for appropriate PPE use. And also we widely set up the alcohol dispenser for hand hygiene. And we set up a guideline for appropriate PPE use to our healthcare workers in accordance with Taiwan CDC guideline. You can see different healthcare workers at different, they should take appropriate PPE according to the guideline to protect themselves and also to protect their patients. And very important to avoid fomite transmission of the virus. We in our hospital, we widely set up the so-called alcohol dispensers at every checkpoint of the hospital, and to encourage hand hygiene, and also to avoid fomite contamination in our hospital environment. And again, as I mentioned earlier, during the pandemic, and also during the recovery phase of the pandemic, in our hospital operation, it's very important to do universal screening for all the inpatients and their accompanied persons before they enter the wards. And we also have to screen all our patients who need invasive procedures for either diagnosis or treatment. We also, of course, we also regularly screen all the healthcare workers working in the yellow and red zones and by PCR, and for the safety of our colleagues. And in terms of the in-persons and accompanied persons screening, since May 16, I think, all inpatients admitted via ER, either adults or children, they should receive. Second, all the accompanied persons of the inpatient admitted via ER or via OPD, they order the hospital. Should the alternative accompanied person be necessary, the self-paid PCR should be performed for the newcomer, for the new ones. We also label all the PCR negative and qualified accompanied persons with the yellow wristband, as shown here. And if they leave the hospital, the wristband will be moved to removed. And then if they come back, they must receive another PCR check to get a new qualification to be in the hospital. In this way, we can avoid cross contamination of the virus from the outside environment, especially during the high peak of the epidemic. As mentioned earlier, we also did outpatient screening, especially for those outpatients who need procedures during the pandemic. For those who need non-invasive procedure, if they can wear the mask throughout the procedure, and if the procedure is less than 15 minutes, they can receive just rapid screening before the procedure. If the procedure is short, less than 15 minutes, they even do not need any screening before the procedure. But if they cannot wear the mask, this means the procedure may involve the mouth or airway. The pre-procedure PCR screening is necessary. Otherwise, physicians are encouraged to postpone the procedures to the after the epidemic is well controlled. For those who need invasive procedure, if they can wear the mask throughout the procedure, again, if the procedure is longer, they need PCR screening. If the procedure is short, they don't need PCR. They don't need a PCR screening. For those who cannot wear the mask and they need during the invasive procedure, of course, PCR screening before the procedure is necessary. Otherwise, the procedure must be postponed. And having said that, we still encourage our physicians to limit the number of all procedures to the lowest level during the level 3 alarm of the country. And to prevent hospital clusters of COVID-19, and also to maintain sufficient manpower during the epidemic for our hospital, I think it's very important to group our healthcare workers for their service. And also we have to monitor the staff health during the epidemic. This is a table showing you that we actually divide our surgeons into 3 groups, and each group actually serving patients in one ward only. In this way, we avoid any possible cross contamination by the virus among our healthcare workers. And in terms of healthcare worker health monitoring, we require them to report body temperature and also any respiratory symptoms every day. And the healthcare workers are also required to report their TOCC every week. And you can see from here, actually, the adherence to this requirement for health monitoring of our healthcare worker is quite good. And we, in Sangam Memorial Hospital, we actually devised an app, the e-service app for staff health management. And also this app now can also be used for visitor control. And we set up the protocol for any healthcare workers in Sangam Memorial Hospital who have symptoms, fever or cough during the pandemic. First of all, any healthcare worker who have symptoms, first of all, they have to inform their superior, and then they have to stop work. And then they will be led to see the physician for evaluation. And if necessary, they will be screened by PCR. Only when they are febrile and also the PCR result come back negative, they are allowed to come back to work. And finally, I think it's very important to provide up-to-date essential information about COVID-19 to all our healthcare workers. And our hospital provide latest up-to-date epidemic information from local and also global perspectives to all our healthcare workers. This information will be posted in the web and also will be provided to the healthcare workers in many meetings. And also hospital provide evidence-based knowledge about the infection control procedures, such as the appropriate PPE use to all our colleagues. And hospital provide updates on COVID-19 diagnosis and treatment guidelines to our staff. And also provide updates on evolution of the virus, especially the emergence of variants of concern to all our colleagues. And very importantly, we provide update information to all our colleagues about vaccines. As of August 24th, more than 99% of our healthcare workers in Sangam Memorial Hospital already received 1 dose of vaccine. And more than 80% of them actually received 2 doses of the COVID-19 vaccine. And I think the general concept is that only science can silence the anxiety and fear of our patients and also of our healthcare workers. A very important thing is that Chang'an Memorial Hospital set up a command center for the purpose of controlling, preventing, in fact, COVID-19 outbreaks in the hospital. Actually, we have meetings twice a week since January last year. So far, I think we have had more than 160 meetings specifically for infection control of COVID-19 during the epidemic. I think unity is the strength, and also to get this point, sufficient communication through the meetings and communications, very important. And so, as mentioned by Professor Fan, we already faced the challenge of the second wave of the infection, but we managed to control this infection epidemic in the community and also in the hospital. But the war still going on, so we have to work together and finally to the final success, hopefully. Okay.
One question. You want to answer now or
Okay, okay.
I think
Thank
you very much, Professor
for your excellent talk and sharing our experience in Taiwan, especially in Chang'an Memorial as a hospital, as a medical center, the biggest medical center in Taiwan, how we managed to contain the infection and outbreak. And I think we provide some information and experience. I'm sure that this is all the challenges we will face in the future. As I say, as we heard previously, balance between infection control, economic maintenance, and also we have to think about how to maintain a good health system for our patient needs. So I think thank you very much, Professor Chu, for your excellent talk and sharing the experience we have in Chang'an as an example of the whole nation, how the hospital, basically what we see the hospital in Taiwan is doing. So maybe for the time frame, I think we will come back for the question later. And we will hand back to UM for our last speaker and the most important speaker probably in this meeting, to Professor Victor, to Professor Tarani for the introduction. Thank you.
Thank you, Prof. Chu. That was very interesting. I like your statement. Unity is strength and communication is key. Right. So very, very, very important statements. I would like to introduce again Prof. Victor Ho, who is our head of department at Department of Social and Preventive Medicine, and also at the Public Health Department at University Hospital, University Malaya Medical Center. He is a professor of occupational and public health. He has a master's in engineering, and he is a member of the COVID-19 task force of the hospital since the beginning of the pandemic. So he has a lot to share of the many experiences that we have in fighting COVID in our hospital, preventing nosocomial infections. Without further ado, can I introduce Prof. Victor? Welcome, Prof. Victor.
Thank you very much, Dr. Tarani. Thank you, everybody. Thank you for having me here today. I hope that you can see my screen, and the screen shows challenges of healthcare services during COVID-19 pandemic in Malaysia. All right. If that is the case, then I will just proceed. Thank you very much. So let me start off by introducing myself again. I'm Professor Victor Ho, and this picture actually shows the time before COVID. This was on New Year of 2020. So I was in Japan, actually having my last skiing trip there, and it was quite enjoyable. So we are hoping that the life will return back to normal, and we would get back to this type of activities later on. Hopefully, maybe by the end of this year, if not early of next year. So I would like to travel to Taiwan to look at for some R&R Basically, we are very tired already, working since 2020. So how it all started, all right? So this is 26th of January 2020. We have 4 cases coming in, and I think that Prof. Awang has basically explained to it. And basically, this is what Malaysia actually have been facing. So on the 25th of January, we have our first case, and also in the University of Malaya Medical Center where I work, we have our first what we call PUS. So under surveillance. So then this is what happened, and this is what what happened on the 26th of January, which is second day of Chinese New Year. I'm sure all of you remember. Basically, I have to come back to work on the 26th of January 2020 because the first case of PUS landed in our hospital on the day before, and we basically activated our COVID-19 task force. So this is the COVID-19 task force on its first meeting after the first case, basically, but the task force actually has been in place since 6 January 2020 with the information coming out from China. So basically, that's what we have been doing. So and this task force has been basically very active all the time, and it was having a daily meeting until the case come down, and then we have basically off and on meeting. Currently, now we're having a weekly meeting and reporting on most of the issue is basically number of cases in the hospital and the hospital workload. So this is just a summary of what's happening in Malaysia and what's the new cases. Prof. Awang have explained this earlier. This is just to show again. This is basically yesterday's number. All right, and this is the active cases. This is new death cases and total death cases. And vaccine doses. So we have basically 13 million people have a second dose of vaccine, and 18.2 million have first dose of vaccine. So now let's focus back on University Malaya Medical Center. So University Malaya Medical Center is a tertiary hospital. It has 1,623 beds, more than 40 specialists and subspecialties. All right, and 36 operating theaters, 5 ICUs, and more than 8,000 plus healthcare workers. So we have a lot of people coming in. Basically, they say that during the normal times, one of our hospital actually is as active as our main shopping mall in Malaysia. Basically, as active. Basically, there's 10,000 people coming in every day plus the 8,000 we have. So we have 20,000 people actually coming through the hospital every day. So it's more active than some of the supermarket and hospital in shopping center in Malaysia. So we serve basically 1.12 million patients annually, and we have the COVID task force was established, as I mentioned, in January 6, and basically was activated on January 26, and a core team basically to look at coordinator representative from all departments. As mentioned earlier, basically unity is the key, and we have basically all the departments is represented, looking at every single aspect, including looking at the PPE stock. As we all understand, during one period of time, PPE is the most important, and then the stock is dwindling because of the production. It basically have stopped in China and in other places. So we have a lot of problem during that beginning time. But currently, there's not much problem. Basically, we have planned our stock earlier, so we don't have at any time basically lack of personal protective equipment for our healthcare worker. So this picture actually shows the hospital itself. We have basically many buildings. All right. So we have an outpatient department. We have Menara Utama, basically our main block, which is medical and surgical. We have Menara Selatan is our south block, rehabilitation medicine, sport medicine, endoscopy, neurology, and biomedical imaging and cardiology. And we have a trauma and emergency building. We have an old building to look at trauma and emergency. Then we have our east block, basically looking at the clinical diagnostic lab, hemato, nephro, and ENT. And also we have a women's and child health care, looking at pediatrics and obstetric and gynecology. So this is during normal time. This is what our hospital looks like, and this is what the building looks like, and this is how who is served. However, after COVID, basically our Menara Utama, our main block is basically converted to COVID-19 block, and we have basically COVID-19 blocks in pediatrics and also in ONG. So there's patient in ONG and patient in what? So our whole block basically 13th floor. We have basically 13th floor, all right, of beds of wards, and that is where we house all our hospitals. So during the peak time, actually we have more than 600 over beds, and also more than 40 ICU beds being allocated for patients in the hospital. So this is, we are talking about hospital currently, but let us move on to what we actually do in our public health department in the hospital itself, and how the public health department actually, with the establishment of the public health department, how it actually has contributed to ensuring or to monitoring the outbreak or cases in the hospital since we began. So this is where are we now, basically in the hospital itself. All right. So this shows the number of cases in the hospital reported by healthcare workers in the hospital who are basically positive, and this reflects what is happening in our community, basically in Kuala Lumpur, where our cases basically has been coming up since on week 32 and currently is going down. So we have a peak of 101 healthcare worker being positive, and this is then we are wondering whether healthcare, how we manage this positive healthcare worker. All right, so in 2021 we have 802 healthcare worker who is basically COVID positive. So around 10% of healthcare workers COVID positive, and in 2020 and 2021 by 60. So basically, we have around 860 healthcare workers who is positive until this week. So basically, most of them are, as you see, community acquired. So most of them get from community because they stays in the community, and COVID-19 is in the community currently. And if it's community, basically very difficult for us to prevent, because most of them actually get it from their relative, get it from their families, and some of them get it from their friends when they go out during meetings where the movement restriction is not so strict. And 22% get from healthcare worker, 11% get from patient, and 6% also communal, and around 7% is indeterminate. So if you look at it, the transmission that happened in the hospital basically happened due to healthcare worker to healthcare worker transmission, and this is because of their lack of adherence to SOP during the period when they are meeting their friends and families. So the number of people actually getting COVID-19 from patient exposure itself is very small, and most of the time when people basically getting COVID-19 exposure, healthcare worker getting COVID-19 exposure from patient or also common infection, is because at the point of time we don't know whether the patient is positive or not, and the symptom of the patient is basically very indeterminate, and only afterward when we do testing again, RT-PCR test again, and then we find that the patient is positive, and when we do contact tracing and we find the healthcare worker become positive. So that's what happened. But most of the cases that we see here is basically healthcare worker to healthcare worker transmission in hospital and also community transmission. So the idea is that we need to set up a system that actually can monitor, maintain, and track and trace this patient quickly so that we can manage them easily. So what's the difference between 2020 and 2021? Basically, 2020, we have more healthcare worker to healthcare worker transmission compared to community transmission, because we are at the beginning of the COVID-19, and a lot of people still don't understand what do you mean by SOP, although we mentioned to them earlier and we discuss with them all the time, but they are not clear about what is to mention to SOP. But currently, basically, in the 2021, there's more cases of more cases of community transmission, and that is because of the high number of cases in the community. So now we talk about what does the role of the public health department in the University of Malaya Medical Center. So this public health department, basically, the activities that we do during the period of COVID-19 basically is, so We have basically harmonized the COVID-19 prevention measures, setting up UMMC COVID-19 healthcare work surveillance operation room. So the objective is to rapidly identify, follow up, and closely monitor healthcare workers in the contact with COVID-19 patient. All right, so this includes patient itself and also include healthcare worker who is COVID-19 positive. To do risk assessment and manage healthcare worker exposed to confirmed COVID-19 cases. To monitor symptoms of healthcare workers in contact with COVID-19 patients for early management and prevention of spread of the disease. And to investigate and control COVID-19 outbreaks occurring within the University of Malaya community. So basically, we are doing it for the hospital. If any cases of outbreak, and we define outbreak as any two cases coming out from the same location, that's where we define it as an outbreak. So what are the main activities we do? Of course, we do contact tracing, and then we do risk assessment. So all healthcare workers basically who is close contact to a patient or close contact to a healthcare worker who is positive need to do risk assessment. And after that, after doing risk assessment, and they will be classified into different risk level, and basically we continue with surveillance. Where we do daily surveillance, and after that we also do what we call hospital outbreak management, where basically we investigate the outbreak in the hospital, we call for meeting and identify the root cause of the outbreak, and basically we go and do even walkthrough visits and things like that to identify what's the root cause of the outbreak. So we talk to people, we call up people. We call up all these people exposed, and also we go to the location to see how does the outbreak occur. So this is the workflow of the COVID-19 work committee. So if positive cases, notification by infectious control to contact tracing team, we do contact tracing. So after contact tracing, the healthcare worker will be asked to do risk assessment. And then after risk assessment, we basically based on the risk level, we basically manage the case, and risk assessment provided list of patient under investigation for surveillance, and then we will basically survey them, and the surveillance team is basically doing daily surveillance. If any symptom that happened during the daily surveillance, the healthcare worker is basically is referred to our special staff health clinic, where basically we only receive cough and cold cases, upper respiratory tract infection, lower respiratory tract infection, and also COVID-19 cases. So we have set up a special staff health clinic. We'll basically see all these cases. We have another staff health clinic. We've seen other cases like chronic cases, and other cases that is not upper respiratory tract or lower respiratory tract infection. So we have set up two clinics because we separate the clinic so that there is no cross infection in the clinic itself. So what does the contact tracing team do? So contact tracing basically is, we talk about, is timely, thorough contact, can effectively interrupt transmission. Contact tracing is based on latest evidence, a median incubation period of 5 to 6 days. The case already infected up to 48 hours before the onset of symptom. Transmission believed to be mainly via respiratory droplet, direct contact with infected person, and indirect contact with surface of subject. So the objective is to rapid identification, follow-up, and close monitoring of healthcare worker who is close contact to COVID-19 patient. So when we identify a COVID-19 patient or healthcare worker, we look at 2 days before that and look at it and contact trace everybody within the 2 days to see whether who is in contact. So this is about contact tracing. That's what we do. But sometimes we do what we call outbreak investigation, where we ask the patient 14 days history. So the 14 days history, we identify what is the cause of the outbreak, what's the cause of the infection. So we do that also if there's the cases of where the contact is basically we are not sure where the healthcare worker get the infection, and we do outbreak investigation where we look at it for 14 days. And then we do risk assessment. Objective of risk assessment is to risk assess and manage the healthcare worker exposed to COVID-19 patient. Activities includes risk assessment, healthcare worker exposed to COVID-19 confirmed patient, management of healthcare worker exposed to patient with confirmed cases, screening of healthcare worker with red visa. So as mentioned earlier, basically we also have what we call a online system using a website or web-based system that we basically look at how to do risk assessment, all right, and also visa. So surveillance. So surveillance is basically what we do about surveillance is as I mentioned, when there is a PUS, we do daily surveillance for 14 days to see whether they have symptom or not. So objective is to monitor symptom of healthcare worker in contact with COVID-19 patient for early management and prevention of spread of this disease. So any patient who basically confirmed to have symptom will be asked to go to our special staff health clinic, where they'll be seen by doctors, and if they have got symptom, there will be RT-PCR will be done to basically to rule out COVID-19 infection. So we started off by basically having a COVID-19 healthcare worker contact tracing and surveillance team, and we have a large number of people. We have around 40 people in the team itself who basically do contact tracing and management in the early 2020 during our first movement control order or lockdown. During that time, we need so many people because we have not developed our online system, and after developing our online system, currently we're only working with around 10 people, 5 in the contact tracing and healthcare worker surveillance team, and 5 in the risk assessment team. So we have around 10 people who are currently working on it, because we have developed a UMMC portal and also the online system. So the online system is basically based in a UMMC portal. It's a portal that the healthcare worker and all the workers in UMMC, including contract workers, including students, basically can access the portal, and they can basically do everything in the portal to manage case. So the first thing in the portal we have is basically the latest information. As mentioned, we have the latest information on not just what is happening in the country, but also what is happening in the hospital, to see how many beds are basically all occupied, what is the ICU capacity, how much are we doing. So we do that in the hospital itself. And also we do what we call healthcare worker risk assessment. So we have requests for risk assessment, list of surveillance feedback. So we have a system in the hospital itself that the patient can actually, the healthcare worker can go to and do their own risk assessment. And we, in the back end, can manage the risk assessment, have a list of the patients, everything, so that we can have a central management without having too much problem. So when the healthcare worker basically click on the risk assessment, they will basically be presented with a set of questionnaire where they answer everything. And after they answer the questionnaire, they will basically be given what we call a outcome, basically to see whether they are high risk, low risk, or moderate risk. Sorry, high risk, low risk, or medium risk. And if they have medium risk, basically we provide action, what they have to do and what they need to do, so that they understand how to prevent the disease. All right. So as mentioned, is here they basically need to do 7 days of home surveillance. All right. So we also have a list of report from our system. Basically, we can see who are moderate risk, who are high risk, and if the people doing the risk assessment are looking at the risk level and need to reconfirm, basically they call up the healthcare worker to reconfirm. And the system also basically have daily surveillance. This will be sent to the healthcare worker who is on home quarantine, and they go to do daily surveillance. Those that is not on home quarantine, who is basically low risk, also need to do daily surveillance, and they will basically do the surveillance and they answer it. If they don't answer by a certain time, like 9 o'clock, they'll be sent the SMS. If they still don't answer after the second SMS, then we will call them after 12 o'clock to see whether they're still alive or not in their home, or still whether they have any other medical problem. Because we like to follow up our healthcare worker to ensure that they are safe. So this is also about surveillance. So they look at it. So the surveillance feedback will say that okay, please go to SSC, all right, because they have symptom and things like that, all right. So basically, when you have symptom, the surveillance will ask you to go to SSC. SSC is our special staff health clinic. So the other thing that we mentioned before is basically our visa. Our visa basically is something similar to what you have before entry. All the healthcare worker, all the patient, all the visitors need to fill in the visa. And basically, if they have red visa, then our healthcare worker will be referred to go to the special staff health clinic for them to basically do assessment. So the special staff health clinic is basically a what we call a walk-in clinic. Any healthcare worker who is in UMMC, including their family members, can actually come in and go to the special health clinic for follow-up. So this is what the visa looks like, and this is we can answer that. And the visa will basically look at it whether you're green or red, and if you're green, basically you can come in. If you're red, then it basically asks you to go to the special staff health clinic for assessment. So this visa basically is a web-based visa, so you can use your handphone to actually answer the question. So thank you very much, and I'm open for questions.
Okay, thank you very much for all our speakers today. I think we heard our four speakers and we learned really a lot from each other. And we are facing a common enemy. I'm sure that we still really need to work hard and that we always vigilant. And I think COVID-19 is not an infection that can be easily controlled. So far, we see. So it will be lasting for a while, and the virus will stay with us for a while. So we hope that everyone enjoyed the information and data from the speaker. So we still have a little bit of time. So I would like to save the time for audience and for questions. So I think I saw one of the questions coming from probably Dr. Mohammed Kahir. He's asking in Changan, a PCR test done weekly for healthcare working region as part of the universal sampling. He would like to know if this action is sustainable, especially in the sense of human resources and the financing costs, and how we are dealing with this issue. Maybe let Professor Chu, our committee chairman, to answer these questions.
The action actually is. Can you hear me?
Yeah.
Okay. The action actually, PCR screening action is actually sustainable, and our the action for the screening actually is sustainable even in the recovery phase. The epidemic clinic of our hospital actually has the capacity of screening more than 1,200 cases a day. So they provide screening service for all the planned inpatients and also for those outpatients who need procedures, invasive procedures. So it's sustainable. And most of the procedures and screening procedures actually funded by the government for free. But some of them actually must be self-paid by the patients.
Okay, thank you, Dr. Chu, for your answering. There's one more question from our Professor Ong. Professor Ong is online now. Thank you, Professor Ong, for setting up this UM and CGMH meeting in the beginning. So your question is that whether we have 80% of our healthcare workers already got 2 doses of vaccine. I think it is not only in Changan. I think the whole medical center, the whole hospital in Taiwan, the medical staff is the first person, or is the first category that who will receive the vaccination when the vaccination program started. Although in Taiwan the vaccination program started a little bit late and we have a little bit trouble in the beginning, but so far I think we also doing quite well. And now we also having our own vaccine. But here we mostly are using Moderna and AZ itself. So most of the worker is having AZ and Moderna. So we don't have the Pfizer one. Probably it will come in the September. So my brief answer to your question. Besides this question online, is there anything else that we want to bring up and share Professor Ong, you'd like to speak a few words?
Yeah. Thanks to everyone, and also to the team led by Professor Yacob Pang from Changgung Memorial. So thanks for the collaboration and thanks for the webinar as well. So I got one more question actually there. I typed it there. I know Taiwan have a homemade, made in Taiwan vaccine. Do you think you'll be popular later on?
Professor Chu, you want to answer?
Yeah, the Taiwan made vaccine, the Medigene vaccine actually just got the EUA of Taiwan FDA, and they started to, this vaccine now started to be distributed to the general, to the people in Taiwan for vaccination, just beginning this week. Yeah, so just begin. I mean, as Professor Fong said, most of the people previously received either AZ or Moderna vaccine. But since this week, the government also provide, EUA granted homemade vaccine to the general population. But usually the people will be asked what kind of vaccine they want to take. It's not mandatory. You have to take any vaccine. You can decide which vaccine you want to take, and they can answer through an online system. And beginning this week, I think Taiwan homemade vaccine now started to be distributed to the population, to the general population. And now I think until late September or October, we will have BNT vaccines coming in. Yeah.
One question to UN colleagues in your hospital. Do you like us? We do routinely screen our inpatient, and now how is your medical service carry out in the time of this outbreak? In the past 2 weeks, we almost shut down non-necessary medical services, but now we are gradually bring back our patient and have our patient admitted to hospital for treatment. But we do have to screen all of them. So I wonder how would you manage now and the future of your regular patient services?
I think this question, Professor Ong would be best to answer. Professor Ong is our surgeon here, and then he's the one most affected by, we are not admitting a patient in a surgical ward.
I think the service effect, it depends on how high the case. So for Taiwan, maybe not that bad because your case number are very low. So for us, the case number is very high. So our service are all affected. The surgical service, the non-COVID service they are severely affected. So our bed number had cut down for original 100%, now probably about 20%, 10-20% of surgical service. So same as other non-COVID services as well, especially in around the capital city. But I think these few days, and hopefully in 1-2 weeks time, thanks to effort from all the experts here, Prof. Awang, Prof. Victor, Prof. Tarani, I think the number is coming down. Hopefully in the next few weeks, we will slowly open up more ward and services for the non-COVID patient who has been having limited service for the last couple of months. So this message also direct to Professor Victor. He sits in the COVID task force. So tomorrow I need your help. Yeah, open up more ward for the non-COVID patient. Thanks a lot in advance.
Thank you very much, thank you very much, Prof. Ong. So basically, that is what's happening in the service department, and also for us, we don't do regular RT-PCR for all patients, but only for patients that are basically going for surgical procedure. And of course, we do it for our people coming in to visit. So the thing is actually quite flexible, but one thing that we don't do is we don't do it regularly for all our staff. So our staff just have to follow their SOP. We only do when there is an outbreak, and then we do a mass screening for the outbreak. Can I have one question? What is your time for you to get back the result for RT-PCR? Ours, we do it in the morning. We might get it around 7 o'clock at night. So if we send it before lunchtime, we might get it around 7 o'clock at night. So it's quite a long period. So how fast do you get your RT-PCR result?
Can you hear me? Yeah. We have a very good clinical microbiology lab, biology lab. Actually, I think 8 to 12 hours, we are able to get the PCR result. Sometimes if the PCR screening, the amount is very high, sometimes we pool the PCR, 5 samples in a PCR to do initial screening. So that can, speed up the result, getting the result.
And also probably the cost can go down.
Yeah, cost can go down.
Could I ask one last question before we close? Could you all share the success in Taiwan bringing down the cases from like 600 cases a day in May to now down to 10 cases? What is your secret of success?
I think this question has to go to although we are hospital-based experience, but I think Professor Chu are also involved in the national policy.
I think 2 key points. One is the leadership from the MOH. This is very important. The other one is the rapid rollout of the vaccines we get. Although it's slow, very slow, but I think after May, the rollout is quicker. So this is another very important point.
Maybe I can add in my own observation. I think the awareness of the public and also people willing to cooperate with the government. As you see, we are in the same room. We all have to wear masks, and so far, I think we have bring down the level of alert to level 2, but we still impose that everyone, when they meet together or go out to anywhere, they have to wear a mask. Basically, I myself is very believe of using masks. I think although we have now probably coming with a lot of VOC, new variant, but I think how to keep a good social distance and wearing masks is still a very essential job that we have to, our daily activity we have to keep in mind. So this is my own opinion, but I don't know whether Professor Lim, you want to say something on this?
Yeah, I totally agree about the mask policy, and the public response in Taiwan is very highly responsive to wearing masks to everywhere. So I think it's also take very important determinant of how we successfully decrease the daily new cases in Taiwan. Yes.
This is our short answer. Probably there's a lot more to discuss, but I'm afraid that we still have to stick with the time frame. I believe that this outbreak pandemic teaches us a lot of lessons, and we are still learning. And also, like I say myself, we have to live with this virus for a while. So hopefully we can end the war soon, and at least we have to know how to contain this virus to a minimum effect to our daily life. But until we see the light on the tunnel, on the other side of the tunnel, but we still have to work very hard. So without further ado, I think we surely have to close this meeting now. Once again, thank you for all the participants and especially the speaker, and also for Darani for your arrangement, and our good staff, Zura and Kenny for setting up all the meeting procedure. So we will see you soon, like Professor Ong and Professor Victor expect. hope to see you next year. Hopefully, we can get everything controlled. And
Yes, we'd like to
visit us in Taiwan and enjoy
we would like to see you here in Kuala Lumpur also. We hope that you can come to Kuala Lumpur and support our tourism industry. Please come.
Same here. We are having an economic crisis.
Thank you very much. Thank you very much for inviting.
Take care. Bye.
Thank you. Have a nice day. Bye. Nice talking to you.
Bye-bye.